Puerperal disorders. Psychiatric disorders associated with childbirth include maternity blues, depressive disorder, puerperal psychosis. Maternity blues. Etiology and psychopathology. Biological factors include the following. More common in first pregnancy. More common in those with a history of premenstrual tension. Not related to complications at delivery. Modestly associated with marked postnatal fall in progesterone levels. Epidemiology. Occurs in 50 to 70% of women, mainly on the 3rd to 4th day after delivery. Clinical presentation. The midwives or partner might report lability of mood, tearfulness, irritability. There tends to be a rapid and spontaneous resolution to these problems. Treatment. Provide support and reassurance. Postnatal depressive disorder. Etiology and psychopathology. Predisposing factors include previous depressions, recent adverse life events, marital conflict, lack of social support, younger age, poor relationship with own mother. Epidemiology. Occurs in 10 to 15% of women. Clinical presentation. It usually starts about 2 weeks after childbirth, but can start at any point up to 3 months after delivery. The clinical picture is as in non-psychotic depression. Treatment. Psychosocial interventions. Antidepressants for severe or persistent symptoms, see below. Counseling and mother and baby groups to reduce isolation. Prognosis. NB. Outcome of postnatal depression. Untreated postnatal depression can last for up to 2 years with damage to relationships, emotional and cognitive development of the baby, any other children. Risk of further episode is 1 in 6. Puerperal psychosis. Etiology and psychopathology. Genetic, if there is a strong family history of affective disorder. Environmental, social stress is not implicated, unlike postnatal depression. Hormonal, postpartum fall in estrogen causes supersensitivity of dopamine receptors. Epidemiology. The frequency is 1 in 500 births. Risk factors include past history or family history of mood disorder, premipara, older age, giving birth by cesarean section. Clinical presentation. Usually an affective, especially manic, disorder, but 20% of cases are schizophrenia-like. Onset tends to be abrupt and in the first 2 weeks postpartum. NB. Management of puerperal psychosis. Antenatal identification of high-risk mothers. Move those identified to a specialist mother and baby unit with nurses trained in both mental health and baby care. Attempt to preserve mother-child bonding. Conventional treatment of depression, mania, or schizophrenia, including electroconvulsive therapy if necessary. Breastfeeding. Assessment of mother-baby interaction before discharge. Monitor the mother carefully during subsequent childbearing. NB. Risks of puerperal psychosis. Suicide. Neglect of child, and of other children. Harm to the baby if the mother holds delusional ideas about the child, and of infanticide followed by suicide. Prognosis. The prognosis is good for immediate recovery, but there is a risk of recurrence in 30–50% of patients if they have subsequent deliveries, and 50% of patients develop non-puerperal depression. NB. Perinatal psychiatric drug treatments. Lithium. Avoid lithium in pregnancy and after delivery if possible, because in the first trimester it can cause atrialization of the right ventricle. The renal clearance of lithium falls abruptly after delivery, which causes a dangerous rise in serum lithium. Lithium is secreted in breast milk, and if the infant becomes dehydrated, toxic lithium levels develop rapidly. Carbamazepine and valproate. Avoid in pregnancy if possible. Antidepressants. Amitriptyline or imipramine are used because more data about possible teratogenic effects are available. Tricyclics in the third trimester may cause neonatal withdrawal effects, e.g. irritability and seizures. Other psychotropic drugs and breastfeeding. When giving a mother psychotropic drugs, remember the following. All psychotropic drugs are secreted in breast milk, therefore use the lowest effective dose. Time feeds to avoid peak levels of drugs. Avoid use of more than one psychotropic drug. Monitor for development, sedation, and irritability in the baby. Check the baby's hepatic and renal function. Use sertraline or tricyclic antidepressants, amitriptyline or imipramine, because more data are available about their effects. Use chlorpromazine, trifluoperazine, or olanzapine for the same reason. Pseudocyesis. Pseudocyesis is a rare condition in which the patient erroneously believes that she is pregnant. She has amenorrhea and abdominal distension. The conviction that she is pregnant is so strong that the patient prepares for the delivery by buying a cradle and baby clothes, etc. In addition to amenorrhea and abdominal enlargement, there may be swelling and tenderness of the breasts, together with morning sickness and sometimes pica. The majority of patients claim to feel fetal movements. The psychological basis obviously includes an intense desire for children. Hyperprolactinemia can mimic pseudocyesis since it causes amenorrhea, galactorrhea and abdominal enlargement due to obesity or water retention.